Good morning and good evening to all the participants for today's webinar, depending on which part of the globe you guys are in. And Dr. Truptesh, Kothari and myself, Amol, Bapaye, we are happy to welcome all of you to the new session of this East Meets West webinar, which we conduct every 3 months or so. Now, the topic for today's webinar is applications of LAMS, or lumen opposing metallic stents. This webinar is brought to you by the Foundation for Research and Education in Endoscopy, a non-profit organization which focuses on research and education in the field of gastrointestinal endoscopy, through a generous academic grant by Boston Scientific Corporation. Today's topic of applications of LAMS, we have divided it into 4 talks. So we will have 4 speakers from the East as well as West, 2 from East and 2 from the West. And the topics will be technical differences between lumen opposing metallic stents and bifurcating metallic stents, and managing adverse events during lumen opposing metallic stents. Followed by that, we'll have endoscopic drainage of pancreatic and non-pancreatic fluid collections using lumen opposing metallic stents. Then we will have EUS-guided gallbladder drainage and choledochoroidectomy, and EUS-guided gastrojejunostomy and edge procedures. So our experts for today's webinar from the East are Professor Anthony Teoh. He is an honorary consultant of general surgery and an extremely accomplished endoscopist and endocrinologist. He was till recently at the Prince of Wales Hospital, and he's recently moved into private practice at the Hong Kong Sanatorium and Hospital Limited. Along with him, we have our own Indian star, Dr. Sudipta Dhar Chowdhury, who is the professor and head of Department of Gastroenterology at the Christian Medical College, Vellore in India. And may I invite Dr. Truptesh now to introduce our experts from the West. Truptesh, over to you. Truptesh, you're muted.
Welcome, everybody, and thank you, Dr. Bapaye, and all the faculties who have taken out their time on a Saturday for this educational mission. And we have 2 stars from the West, Dr. Manuel Perez Miranda. He, because of his family emergency, he is unable to join us, but we have a recorded version, and he will join during the question-answer session. He's the head of gastroenterology and hepatology hospital in Rio Ortega in Spain. And then we have Dr. Harshit S. Khara, who is a clinical associate professor and the medical director of endoscopy at Geisinger Medical Center. So we are happy to have all 4 of our star faculties. And without wasting any time, I would actually hand over to Dr. Bapaye for some housekeeping announcements, and then we'll hand over the podium to Dr. Teoh. So Dr. Bapaye, you want to just announce?
Yeah, some housekeeping announcements. For those of you who may have any questions, please put them in the Q&A box rather than in the chat box. If you have any technical difficulties regarding audio or video or seeing the slides or the presentation, you can raise those points in the chat box. But any questions to the faculty, please put them in the Q&A box. We will run all the 4 lectures one after the other, after which we will have a 30-minute session of live Q&A. And we hope to take as many questions, preferably all the questions that we will have and during this session. And with that, over to you, Anthony.
Okay, thank you very much for a kind introduction, Amol. I'm very honored to be here speaking on a very familiar topic. I'm going to share my slides. To start the session, I'll be doing some introduction in terms of the technology of LAMS, and also the differences between bi-flange metallic stent. And I'll also talk about managing adverse events in the second half of the lecture. So as we know, we came a long way in the development of EUS-guided procedures. In fact, these are not so new procedures because they have been described more than almost 20 years ago. But only in the recent few years that these procedures have really become popular. I think primarily because companies have become interested in developing these EUS dedicated devices, making the procedures much more easier and safer to perform. So with these EUS-specific devices, it allows performance of novel procedures with ease, reduces the difficulty, and reduces the risk of adverse events, shortens procedural time, and also decreases the learning curve. And when we look at EUS drainage procedures in a nutshell, it's basically divided into 4 steps. Puncturing of the target organ, insertion of guide wire, dilatation of the tract, followed by insertion of the stent. So with all these different parts of the procedures, we use different devices, needles, guide wire, cautery, non-cautery dilatation, followed by stent insertion. And the new EUS device allows us to combine all these steps into a single step, making it much more easier to perform. And also, apart from drainage, the role of stents are also evolving. So it acts as a portal for entry. It allows us to go into organs that we've never been able to get into and perform adjunctive treatment. And of course, we need to consider the indications, the need for reintervention, and also adjuvant treatment. Now, we have so many different types of EUS-specific stents. And we can broadly classify into dumbbell type shaped stents, and also tubular type shaped EUS-specific stents, and also plastic stents, which in the past we thought may not be safe to be used, but now with a dedicated EUS-specific plastic stent, it is also safe to use. So for the purpose of today's talk, I'll focus more on LAMS and what we mean by LAMS. And when we design these stents, there are multiple considerations that we need to take into account. The material, whether it's metal or plastic, and if metal, whether we're going to use nitinol or not, type of covering, the way that the metal is being cut, any anti-migratory properties, and how we deploy the stents. Of course, you also have clinical considerations like type of procedure, indications, stent patencies, and also the risk of stent migrations. I think the one most important development in EUS-specific devices is the single-step device. So as I mentioned, it combines all these different steps into one single step. And with newer stent delivery systems, this has been incorporated into the delivery system and allows direct puncture, dilatation, and stent deployment in a single movement. In terms of deployment system, we are all very familiar with the assistant controlled system, but with these new EUS-specific systems, it also allows the endoscopist to have a control over how the stent is deployed. And this has some advantage in that it allows the endoscopist to be more precise, particularly in small targets. And you can do this procedure by yourself, more or less, especially in the absence of a very experienced assistant. But of course, you need some training to use this system. And many of these devices, endoscopist control systems, are more expensive. In terms of luminal pulsing stents, I would classify these 3 stents as luminal pulsing stents. The Axios from Boston Scientific, BTS Baxis from Teoh, and the Hanaro stent from MITech. So these stents all have a dumbbell-shaped design. The flanges at the end of the stent act as an anchor and prevents the stent from migration. It also helps to pull the two lumens together. So I think we don't have a universal definition of a lumen opposing stent, but for me, I think LAMS need to have a high lumen opposing force, flanges of both ends to prevent migration and allows the passage of scope through the stent. Of course, there are some problems with the stent. It may be high opposing force may cause the buried stent syndrome. Edges of the stent may cause bleeding, particularly if it's very close to the vessel. And also food particles can go through the stent, which may be intentional or unintentional. So in the case of GJ, it might be what we want to happen. But in the case of CDS, we don't want that to happen. This study was published many years ago, 2016, which we used a machine to measure the lumen opposing forces of various stents. And at that time, we concluded that the SPAXs and the axial stents have higher lumen opposing force. And most recently, with more stents being available, the Hanaro stent, SPAXs, axials have all been shown to have a high lumen opposing force, and hence should be called a lumen opposing stent. So for axials, nowadays we have a lot of choices. It comes in 6, 8, 10, 15, 20 millimeter diameter. It has a dedicated delivery system, endoscopically controlled delivery system. And the length, also we have multiple lengths now, 8, 10, and 15 millimeters. For the SPAXs, again, it comes in various sizes now. I didn't write out here, but it comes in 8, 10, and 16 millimeter diameter. And also comes with various lengths, like 2, 3, 4 centimeters long. For the SPAXs stent, the flange folds back on itself, so it's a bit different in terms of design. And the distance between the flange would be 8 millimeters when it's completely unfolded. But with the longer distance between the two organs, actually these flanges do not necessarily have to fold completely together. So even for longer distance, this stent can sit relatively well. So this slide has been shown. In terms of the axials, we know the endoscopically controlled system, which you need to learn how to push the delivery system forwards, followed by deployment of the distal flange and the proximal flange. A newer endoscopically controlled system is the EUS IT stent. IT meaning it's designed by Takao Itoi, and it's from MI Tech. So the stent that is lodged on the stent is the Hanaro stent. Lodged on the delivery system is Hanaro stent. The design is in some ways similar to axials. There's a Kothari enhanced tip. There's a sheath lock, which allows us to unlock and move the delivery system forwards. They have a gray spin lock, which when turned 180 degrees, allow deployment of the system, distal flange, followed by another turn around 180 degrees, allows the deployment of the proximal flange. So this video shows the deployment of this system. So here I was performing a GJ. You can, using the freehand technique, tube has been inserted for enlarging the small bowel. You can see the deployment system just burning in through here. It went into the small bowel quite easily, and then I was pushing the delivery system down. Here I turned the knob 180 degrees, which allows me to open the distal flange by pushing this knob upwards. So here you can see the distal flange being opened. Then I pull back the stent. followed by opening the proximal flange in the channel and then pushing out the stent. This is what it looks like after deployment. And so here I turn the knob 180 degrees again and then push it upwards. That was like this, upwards. Completing the deployment, just like that. So this is the Nagi stent, which in this definition, I would not consider a lumen opposing stent. So this is one of the older videos where we used it to drain a ward-off necrosis. It's a metal stent, which has a large diameter. But as you can see, the flange is just flared, but does not provide a lumen opposing feeding. For the hot axials, we've seen these videos multiple times, so I'm just not going to show this one. So that completes my introduction for LAMS. And for the next part, I will talk about managing adverse events. So when we first started performing EUS-guided drainage procedures, I was told that when you succeed, you become a hero, but when you fail, you can fail miserably. And hopefully now with the new systems, we don't encounter this as often. And when managing complication in interventional EUS, we have to be aware that once something happens, you have two problems to deal with. And you need to ask yourself whether you can deal with the problem yourself, whether or not to continue the procedure. Can the patient tolerate another failure? Is there someone who could do a better job in the unit? And also you need to think whether you need to involve other disciplines. Potential complications that we can encounter include standard misdeployment, migration, blockade, perforation, foot impaction, which in my belief, most of these can be dealt with endoscopically. But bleeding, sometimes we may need a multidisciplinary involvement, like interventional radiology or even surgery. Depending on the time available, I'll talk about some of these issues. Stent malposition, stent migration. So this is a video showing the misdeployed CDS stent. This is taken from my book on strategies on interventional ES. It's a video from Amrita. So for the bile ducts, because sometimes it's a very small target, so if we puncture directly with the axial stent, sometimes the tip of the delivery system is in the bile duct, but the stent could be deployed outside the bile duct. So this is what actually happened. The tip is inside the bile duct, but it cannot be pushed completely inside the bile duct. And as a result, you can see the stent is actually deployed between the bile duct and the duodenum. So in this situation, always try to insert the guide wire. But in this case, I think she failed. And after complete deployment of the axials, actually, she was very lucky to be able to cannulate through the stent and re-enter into bile duct. So once inside the bile duct, then what you need to do is just do a stent on stent using the guide wire. So here you can see a balloon. She inserted to confirm the position of the guide wire. And then just insert another straight stent on the guide wire into the bile duct, completing the CDS. And in this case, if the stent can be deployed between the target organ and the duodenum GI tract, most of these patients won't experience significant problems. This is an edge procedure where there's another migration. So after the stent was deployed, ERCP was performed through the stent, but since these stents are quite new, so any intervention through the stent may risk causing dislodgement. And in this case, after completion of the ERCP, the stent was seen to have migrated out from the proximal stomach. So all these are peritoneal contents. And since there is a guide wire still present, so again, what you need to do is do a stent on stent. So in this case, a fully covered esophageal stent was used to bridge the remnant stomach from the excluded stomach, and it was re-anchored with the over-stitch system. Here is a GJ that I was doing. So at this juncture, I think the small bowel was adequately distended, but perhaps not too well distended. But I went ahead with puncturing. You see a bit of movement of the small bowel away from the stomach, and I went ahead. So right here, I sort of lost the view, and I'm not 100% certain if I'm inside the small bowel. And this is what happens if you have this misdeployment. So you see some leakage of fluid. I deployed the distal flange, but I'm pretty certain I'm not inside the small bowel. So at this juncture, I decided to pull out the entire system. So by pulling out the entire system, allows me to repuncture actually for this patient and not have a big hole inside the stomach. So in this case, I tried to distend the small bowel again and actually repeated the EUS-GJ and completed with another stent. So with this study, it tells us that with EUS-GJ, the misdeployment can occur in a number of instances. And with most of these instances, actually, you can deal with it endoscopically. So as I mentioned, for HGS, we can prevent stent migration with a number of strategies to have a long distance of stent in the stomach. And we need to be aware how to salvage my stent migration when it happens. So with HGS, there are a number of different techniques, including the crisscross technique and also placing these clips on the stent to prevent migration. I'm going to talk one more video and end this talk. This is a patient with a EUS gallbladder drainage, which at the end resulted in perforation. So the first part of the procedure went really smoothly. The gallbladder was punctured with the stent and then opened. So right here, I was trying to get an end-on view of the stent as I was talking towards the stent. But as I was talking the scope, I saw this view. So this is outside the peritoneal cavity. I was quite shocked, as you could imagine. And actually what happened is I caused a hole, perforation, right next to the stent, right there. That's the hole. So I actually went between the stent and the GI tract. So for this patient, and then in contrast, you can see contrast leak right there. So luckily, I was able to place clips in the hole to close the defect completely. And finally, contrast injection showed no more leak. So again, telling us that these newly formed anastomoses are very fragile. So you need to take care of it. Okay, so I'm not going to show this. So I'm going to end this lecture By this conclusion, complications in interventional EUS can be terrifying. We should make slow, cautious steps in learning EUS, be friends with radiologists and surgeons, and initially learning best in the presence of experienced endosonographers. But there are great rewards in successful cases. So thank you for your attention. I'm happy to take questions at the end of the 4 talks.
Thank you, Dr. Teoh, for excellent talk. I would invite Dr. Sudipta Dhar Chowdhury for his talk on endoscopic drainage of pancreatic and non-pancreatic collections using lumen opposing metal stent. Sudipta.
Hello. Am I audible?
Yeah, you
Yes.
are. Yes,
Yeah.
you are.
Thanks. Thank you, Truptesh, and thank you, Amol, for giving me this opportunity to participate in this meeting. So I'll just talk to you after this lovely discussion with Anthony showed us all the complications. I'm going to talk to you on a simple aspect of LAMS usage in endoscopic drainage of pancreatic and non-pancreatic collections. So before we go into this, I just wanted to for everyone, because most of us are gastroenterologists and not really surgeons, that we forget the spaces that we have to deal with within the peritoneal cavity. So the spaces where fluid can usually accumulate are usually in the right subphrenic space, the left subphrenic space, the lesser sac, the right and the left paracolic gutter, the right and left inframesocolic space, and of course the pelvis. And in the pelvis, one area, of course, is the pouch of Douglas, which is just in front of the rectosigmoid area. Now, these collections in abdomen can happen from multiple causes. Commonly, we encounter collections related to acute pancreatitis. However, non-pancreatic causes can also produce collections within the abdominal cavity. And these are usually seen in the postoperative situations, where if there's a perforation of a hollow viscus like an appendix, a divertical, or a peptic ulcer, gangrenous cholecystitis, ischemic bowel, or an inflammatory bowel disease. Now, just going into the pancreatic collections, we all have seen these slides quite a lot of times, but just to recapitulate the original Atlanta classification. The revised Atlanta had classified fluid collections in acute pancreatitis into 4 different types. Those occurring within less than 4 weeks in interstitial edematous pancreatitis was acute peripancreatic fluid collections. And if there's necrotizing pancreatitis, we get an acute necrotic collections. At 4 weeks, within 4 weeks, these collections mature to form a wall around it. Either where there's when there's a very minimal amount of necrosis, we call it a pseudocyst, or when the amount of necrosis is large, we call it a walled off necrosis. But most of the pancreatic fluid collections patients remain asymptomatic, and spontaneous resolutions occur in most. However, complications develop in a sizable small portion, that around 30%, and this is primarily seen in patients with walled-off necrosis, and the complications are predominantly in the form of infection, pain, bleeding, and rupture. And one should address pancreatic fluid collections only if the person develops symptoms related to this. So the interventions in acute pancreatitis have had a paradigm change. We started off with surgery, then to percutaneous drainage, video-assisted retroperitoneal drainage, and of course, now looking at endoscopic drainage. Just to summarize the data we have so far, if you look at what happened in 1980s and 90s, it was surgery for all patients with acute necrotizing pancreatitis. Gradually, we moved on to accepting that mortality, if you do a late necrosectomy, the mortality was lower. The landmark trial came out from the Dutch acute pancreatitis study group and showed that percutaneous step-up approach is better than open surgery. Then they again published what was the Penguin trial in 2012, showing the endoscopic necrosectomy is probably better than open surgery. Then came the Tension trial, which showed that endoscopy step-up approach had a lower fistula rate and shorter hospital stay. Ultimately coming back to saying that we don't need to do immediate drainage, and delayed drainage is good enough and allowing the wall to mature. So you can see a whole paradigm shift from surgery to endoscopy for management of peripancreatic fluid collections. So in acute pancreatitis, fluids collections can occur in the lesser sac, around the splenic hilum or the hilum of left kidneys, and this can be easily drained through the transgastric approach. However, collections which are in the left or the right paracolic gutter are better dealt with the percutaneous route. One important area of collection formation is in the subhepatic location, and because that area is predominantly a peritoneal location, and ideally that should be drained with a transduodenal approach. But again, just to mention, this is one area where the collections, if it is there and there's attempted drainage, there's a risk of fluid leakage and peritonitis. So endoscopic approach is primarily feasible for fluid collections which are in the vicinity of the stomach. However, for fluid collections such as this, which are multiple along the right and left paracolic gutter, these are better dealt with a percutaneous technique. So this is just a recent case, as in last week. This is a gentleman with an acute on chronic pancreatitis who came in with a severe pain abdomen. And as you can see, there's a large fluid collection and there's a significant amount of necrosome. The video, please, you'll see that there's a significant amount of necrosome here. And when the necrosis is more than 50%, these are candidates which do not do very well with plastic stents. So we proceeded to put in a lumen opposing metal stent, in this case, a hot axios. So here you can see the wall of necrosis here. And you can see that the necrotic material was extremely high, almost more than 50%. So the size was around 6 centimeters. So the puncture was done directly with a hot axios. I'll just let the video run. And you can now start deploying the distal flange. And then once the distal flange open, the stent is pulled proximally so as to get a tenting done of the distal flange. And the proximal flange is deployed within the scope channel itself and pushed out. We usually follow it by placing of a double pictal plastic stents within the axios. Now, the other thing which Anthony was talking about are the biflange stents, and this also we do more often in patients with acute necrotizing pancreatitis. Here we puncture in with a 10 French cystotome, and then the Nagy stent. This is a Nagy stent, which you can see has opened up within the stent cavity. We stent is pulled proximally and deployed it, and a deployment is done under vision. The Nagy stent is one stent which I prefer to deploy under vision because it doesn't have a lumen opposing capacity. So the risk of this stent migrating inside is much higher than as that of a pure LAMS. But this is more of a biflange stent and not exactly a lumen opposing metal stent. The advantage with this biflange stents and lumen opposing metal stents we have is that we can enter through the stent and go and do necrosectomies. And this is really helpful when there's a large amount of necrosis, thereby this allowing the scope to enter, and we can use multiple devices through the scope to do the necrosectomy. Herein, you can see we are using a basket to remove necrosome. We use a basket, a snare, and now, of course, we have a dedicated rotator device which can help in taking out the necrotic material. But complications do occur with the lumen opposing metal stents and biflange stents, and the complications can be device-related or patient-related. We look at device-related complications, which Anthony mentioned in his talk, was stent malposition, stent migration. And here you can see a stent malposition stent. And this happened primarily because the target was smaller. Premature deployment of the stents, we had issues with material integrity and deployment failure. But the more important are the patient-related complications. And one dreaded complication is, of course, bleeding. Because you can understand that the splenic artery lies at the bed of the stomach, and there's a high risk that the stent can actually, when the fluid cavity decompresses, the stent tends to irritate the splenic artery, and there's a high risk of formation of splenic aneurysms and bleeding. And these bleedings can be life-threatening. Of course, there are other complications include perforation, pain, and infection because of the stent blockage per se. So how does lumen opposing metal stent compare to biflange metal stents when we are talking of drainage of pancreatic collections? This 2020-24 retrospective study, multicenter propensity score match study showed that the overall technical success, clinical success, adverse events were similar. However, the two previous studies actually showed that the stent dysfunction was higher with biflange metal stents, migrations were higher with biflange metal stents, and with the lumen opposing metal stents, of course, the procedure time was lower. So in situations where there's a large amount of necrosome, LAMS may be a preferred option compared to a biflange metal stent. Now, coming to the other collections, this is pelvic collections, and pelvic collections develop primarily in patients who have pelvic inflammatory disease, diverticulitis, appendicitis, or anastomotic leaks. And in the past, we had been doing it primarily with interventional radiology, and of late, we had started doing EUS-guided double pictal plastic stent placement in those patients, and with very good results. Now, there have been attempts at draining pelvic fluid collections with the transrectal LAMS placement. This is ideally preferable when the lesion is more than or equal to 4 centimeters within 1 centimeter of the colon or rectum. However, ascites, or if there's a bowel traversing that area, then that's an absolute no for placement of LAMS. So there's not much data on the transrectal drainage of pelvic collections, except for these two, which I could get. One was a 10-patient case series of 2021 in diverticular disease, which showed the technical success and clinical success was 88%. And this is in 5 patients of post-operative and diverticular disease. Technical and clinical success was 100%. Post-surgical collections can also develop in patients who have pancreatic surgery, and this is very common in pancreatic surgery. In the initial stages, we have these inflammatory collections. We may not see many of them because most of them resolve spontaneously, and many surgeons tend to put in a small drain in that. However, post-cholecystectomy bile leaks also have been reported, and there are pelvic collections as described previously. This is the only trial study which looked at LAMS for drainage of post-operative post-surgery fluid collections. This is a multi-center study from US, 8 centers, 47 patients, predominantly inflammatory fluid and abscesses. This was predominantly a pancreatic surgeries. Of course, there were other surgeries too, but most of the patients, almost 23 patients, 26 patients were pancreatic surgeries. The technical success was 93%, clinical success 89%, adverse events 6%. And if you compare between the technical and clinical success depending on the route of deployment, there was not hardly any difference. Transgastric was 94%, transduodenal success was 80%, and transrectal was 100%. So to summarize, EUS-guided drainage is a safe and effective procedure for drainage of collections close to the gut wall, and LAMS is a viable alternative, especially in patients who may require iterations. Thank you for your patient hearing.
Thank you, Sudipta, for that wonderful talk. And now I will run Manolo's presentation. I will share that. So Professor Manuel Perez Miranda will be joining us very soon, shortly, but he has sent his recorded presentation, so I will run that.
Hello, good afternoon. My name is Manuel Perez Miranda from Spain. It's a pleasure to share this webinar on the application of LAMS. I will discuss gallbladder and common bile duct EUS-guided drainage. First, the rationale and technique, and then how do these procedures compare to alternatives. So in patients at high surgical risk who fail to improve with antibiotics from their acute cholecystitis, drainage is mandatory, percutaneously, transcystic, or EUS-guided. The first EUS-guided gallbladder drainage cases had higher malignancy and used thin double pigtails or nasobiliary drains. Subsequent improvement using still the traditional Seldinger technique with needle wire dilation, use instead a fully covered tubular self-expandable metal stent with or without anchoring flaps in. Here's the waist of the duodenal wall. In those stents without anchoring flaps, a double pigtail had to be inserted to prevent migration to which these stents are prone. Then LAMS appear still using the traditional needle puncture under EUS wire. However, those LAMS had only 1 centimeter in length, which make them prone to misdeployment. Here's the proximal flange in the stomach that is about to go beyond and needs salvage with a rat tooth forceps to prevent peritonitis, but traction needs to be done gently to prevent dislodgement of the proximal flange. Eventually, this was salvaged. The opposite misdeployment may occur with the distal flange lying in between the gallbladder and the GI tract, and that can be salvaged with a fully covered 6 centimeter tubular SEMS. The ultimate improvement, technological improvement, avoiding the tedious needle wire exchange, dilation, and stent, was the development of the hot LAMS, allowing the freehand insertion directly into the target just by Kothari. So here in this retrospective multicenter study, median stent deployment time was 4.5 minutes. If the Seldinger technique was used, however, stent deployment time went up to 7.7 minutes compared to 3.1 minutes with the freehand technique. That is almost 5 minutes of leakage time. So it's not only safe, easier, it's also faster and safer. And to prevent proximal flange misdeployment, the intrachannel stent release technique has been deployed, which is becoming the most common compared to the traditional endoscopic monitoring technique. So after all this refinement, how does EUS-guided gallbladder drainage compare to percutaneous drainage? So in this drug randomized study, patients who underwent EUS-guided gallbladder drainage had significantly lower pain score on the day of drainage and in the first 2 days. But more meaningful, the short-term outcomes is the 30-day adverse event, 13 versus almost 50% favoring EUS gallbladder drainage, and 1-year adverse events, 25 versus 77%. In the drug trial, patients underwent elective cholecystoscopy and gallstone clearance at 4 weeks. However, recent evidence suggests that leaving the LAMS in place for good is also acceptable. So here, 45 patients completed 1-year follow-up with inside of LAMS, and overall, the adverse events rate was 15%, with recurrent biliary events only 6.1%, and patients with pancreaticobiliary malignancy have the highest risk of recurrent biliary events. Finally, internalization of previous percutaneous cholecystostomy can be done by distending the gallbladder through the percutaneous drain with fluid. So the wall of the gallbladder is sometimes thicker and requires dilation. This is an older case, sometimes over the wire, even if it's hot, and these can prevent recurrences. So the patient can be drained in the acute setting by interventional radiologists and then converted electively to EUS-guided gallbladder drainage when everybody is agreed that he or she is a definitive non-surgical candidate. So how about the interaction between EUS gallbladder drainage and the RCP? They can be seen as competitors in as much as a transpapillary drain can be placed through the cystic duct, and this works pretty well. So in the short-term outcomes is in between, technical and clinical success rate are lower than transmural drainage options, and in the long term is in between the highest recurrence and reintervention rates of the percutaneous, but still not as good as EUS-guided gallbladder drainage. Also, availability and cost are somewhat in between the cheaper and more widely available percutaneous, between the more expensive and less widely available EUS-guided drainage. In this meta-analysis with 15,000 patients, cystic ERCP base was significantly lower technical success rate, and clinical success rate were significantly better for the transmural EUS or percutaneous. However, in the long term, recurrence were better for either endoscopic approach. And finally, ERCP and EUS-guided gallbladder drainage can be seen as complementary, in as much as patients can have common bile duct stone and cholecystitis. So combining both procedures into one single session under the same sedation does not appear to increase the risk of adverse events. So if the expertise is there, these combined approaches can be offered to these patients. The ultimate comparator is laparoscopic cholecystectomy, the gold standard, and this retrospective study with propensity score analysis, patients who underwent gallbladder drainage and laparoscopic cholecystectomy had exactly the same outcomes regarding technical success, clinical success, and recurrent biliary events. So this opens the question whether the threshold for EUS-guided gallbladder drainage can be lowered to admit other indications, not just severe cholecystitis in non-surgical, definitive non-surgical risk patients. So how about the use of sequential cholecystectomy after initial EUS-guided gallbladder drainage, where there is a randomized trial in 2012 from Hassan, in which patients had the same outcomes, short-term, and most underwent lap chole, and there was no difference in the conversion rate. However, in this study, nasobiliary tube was used for EUS-guided gallbladder drainage, which is not exactly the same as LAMS. There is some preliminary evidence that suggests these outcomes can be replicated with LAMS. So this is patients combined from Brussels and Hong Kong, 81, mostly undergoing transduodenal gallbladder drainage and then cholecystectomy. LAMS were removed a median of 4 days before cholecystectomy, and the fistula was usually left as such, no closure. And during surgery, fistulas were sutured or stapled, and the median operation time was 45 minutes. And the procedure was successful in all patients. Postoperative adverse events were very good, 3.7%. So it would appear that lap chole is feasible after LAMS placement. However, this is a contingent issue. So let's move on now to biliary drainage. So the rationale for EUS-guided biliary drainage is, of course, ERCP is not perfect, and even less so in malignant biliary obstruction, with a failure rate as high as 17% in registry data. The first biliary drainage report came 23 years back, and diagnostic EUS code was used and exchange over the wire for a duodenoscope, and then drainage accomplished with a plastic stent. Obviously not a very reproducible procedure, and not 100% safe because of the risk of leakage. This evolved into LAMS-based drainage. Look at this patient. ERCP is clearly impossible here after duodenal stent placement in a native fibula. However, puncture of the common bile duct and LAMS with a choledochoduodenostomy is perfectly doable. Obviously, choledochoduodenostomy is not the only option for biliary drainage. We also have hepatogastrostomy, and when the obstruction is located proximally, when patients do not have endoscopic access to the papilla, there's no other option as hepatogastrostomy. When the obstruction is distal and there is access to the bulb, there's a choice between one or the other. So for choledochoduodenostomy, the scope is in a stable, long root, stable position. The common bile duct is larger than the intrahepatics, and the distance from the transducer is shorter. Wire manipulation is easier, and the only step that is easier with hepatogastrostomy is puncture tract dilation, but this can be overcome with the latest generation. So in keeping with those facts, learning curve for hepatic gastrostomy is above 30 procedures for operators already proficient in interventional procedures. In this retrospective French study on choledochoduodenostomy using a LAMS, technical success was 90%, procedure time 10 minutes, adverse events 4%. But interestingly, there were no difference between experts and non-expert operators, suggesting that the learning curve can be, for choledochoduodenostomy, can be flattened with Kothari enhanced LAMS. So indeed, two trials analyze the outcomes of primary EUS choledochoduodenostomy, that is not after failure ERCP as a primary drainage option versus ERCP. And in the first trial, the Drambo trial, technical success was significantly higher for EUS approach. Procedure time shorter, 10 minutes versus 25, and 1 year's stent patency were comparable. In this study, only experienced operators participated and only patients with unresectable malignant biliary obstruction were included. In the ELEMENT trial, very similar outcomes. However, inexperienced operators were involved in the trial with a median of 2 procedures prior to enrollment, and also patients with borderline resectable disease were entered. So is really LAMS-based choledochoduodenostomy perfect or that wonderful? Well, to begin with, in those two trials, only patients with a 14 millimeter diameter common bile duct were included. And in real life, we know that about half patients, the diameter of the bile duct is smaller than 15, and there are even patients, 20%, in which the bile duct is less than 12 millimeter. The other limitation is long-term patency. In this prospective study, the stent, even if technical and clinical success were very high, in the short term, the stent dysfunction at 6 months was significant, above 50%, which is higher than in other studies, but this is a prospective study. So the reason might be the angle between the LAMS and the common bile duct, which impedes the flow and is prone to sludge formation. If a pigtail is placed through the LAMS, the axis may be corrected, the flow improve. Indeed, one trial, Bapaye, looked at the outcomes between patients with choledochoduodenostomy with LAMS and LAMS plus pigtail, and the rate of recurrent biliary obstruction was significantly higher in the LAMS-only group, so what the rate of biliary reintervention and the time to recurrent biliary obstruction was much longer in the group with a pigtail. So how to integrate these discrepant findings into practice? Maybe if the patient does not need FNA, ERCP can be considered the primary drainage approach with EUS-GBD reserved for failed cases, with LAMS if the duct is dilated, or with SEMS if not. If the patient requires FNA, and maybe CDS with LAMS can be chosen as primary drainage if the duct is dilated, and the opposite is true for ERCP. Finally, before I conclude, the gallbladder can also be used as a target for biliary drainage when everything fails, like ERCP, EUS-GBD, then gallbladder. This can be done with tubular SEMS or with a LAMS and provides a reasonable patency, and it would be typically be done in patients without much intrahepatic dilation and some reason that prevents ERCP. But that requires a patent cystic duct. The opposite, if the cystic duct is blocked, the risk of cholecystitis increases, and then prophylactic gallbladder drainage significantly decreases the risk of cholecystitis between 0 and 22%. So in conclusion, EUS-guided gallbladder and bile duct drainage with LAMS are feasible and reproducible Procedures are much simplified with the hot LAMS, yet they remain technically demanding, requiring adequate training and patient selection. Superior outcomes to percutaneous alternatives have been proven in cholecystitis of high surgical risk patients and non-resectable malignant biliary obstruction with prior failed ERCP. Outcomes appear comparable to ERCP in unresectable distal MBO for primary drainage. However, expanding indications need further evaluation and management pathways, further refinements. Thank you very much for your attention.
That was a great talk from Manolo, and he will be with us soon. Meanwhile, I would like to again invite Dr. Khara, who's going to shed some light on EUS-GJ and EDGE procedure. Over to you, Harshit.
Thank you, Truptesh and Amol. So, hello, everybody. And I would like to start off by giving a huge thanks to both Truptesh and Amol for this invitation and to join this all-star faculty panel. And I'm going to continue on this journey of interventional EUS and talk to you about EUS-guided gastroenterostomy, also synonymously used as EUS-guided gastrojejunostomy, so EUS-GE, EUS-GJ, and the EDGE procedures. So as you know, EUS-GE is usually done for gastric outlet obstruction as a complication from gastroduodenal or pancreatic or duodenal malignancies, as well as for benign etiologies like pancreatitis, peptic ulcer disease, or anything that causes a gastric outlet stricture. And the current modalities include, the gold standard used to be surgical gastrojejunostomies, which has been replaced with luminal stenting, and now more so with EUS-guided access. So the techniques from east to west, I thought that was a suiting paper for our webinar, suits our topic as well, is different techniques used are antegrade EUS-GE, which is the traditional downstream method, or a rendezvous technique, or a retrograde where you go into the jejunum and do an enterogastrostomy, as long as that is traversable, or the EPAS technique that Anthony has published a lot on as well, and the antegrade direct freehand method. And now with this new technique, it has become much more easier because you're not married to the puncture site. So I'll make it a little case-based, where this patient of mine had adenocarcinoma in the uncinate area of the pancreas with a symptomatic malignant gastric outlet obstruction in the D3, D4 area. So as you can see here, the stomach is significantly distended as a result of this obstruction, which was along the D3 portion. So if possible, I try to traverse these lesions endoscopically to visually place a wire access, but if it is not doable, then I place the wire under fluoroscopic guidance. And once I do that, I pass a biliary balloon catheter over the wire to get the anatomy and the length of the stricture. So here you can see the balloon is passed beyond the ligament of Treitz, and an enterogram is obtained to figure out where the exact obstruction and the length of the obstruction is. And then through a therapeutic endoscope, I place a 10 French orojejunal drain. So this drain goes, this is technically a nasobiliary drain that I use for orojejunal and turn it into an orojejunal access. So this drain is passed through the endoscope and then exchanged out. And then a therapeutic EUS-scope is placed alongside the drain. I use the drain to insufflate the bowel. I give glucagon to arrest the peristalsis, so the bowel is not moving and is as steady as possible. And then under direct EUS and fluoroscopic, I do a direct freehand puncture into the jejunum. Of course, with caution based on the videos that Anthony showed where you can misdeploy, but here making that the distal flange is deployed into the jejunum and then the proximal flange is deployed into the gastric lumen. The water I stain with blue dye. So this way, when I puncture, I can see the reflux of blue. And as long as it's not stool, you're happy, right? So I want to see blue, not brown. I do immediate same session stent dilation to provide immediate relief. And also this gives me the confidence of looking at the jejunum on the other side. And then this is the post picture showing a patent gastroenterostomy. And the patient is literally able to start an oral diet immediately after the procedure. So the steps that I include are to avoid the issues and complications that Anthony mentioned earlier about not misdeploying or not puncturing the wrong organ. So we did a review and a meta-analysis showing the technical feasibility and the clinical success of this procedure with a adverse event rate comparable to many of our interventional endoscopy procedures. And we have shown that the literature has shown that EUS-GE is comparable to enteral stenting with fewer rate of reintervention, which makes sense because we're not traversing through the tumor or the obstruction. So there is less chances of stent occlusion or tumor ingrowth. And it is equivalent and safe when compared to surgical GJ as well. And in fact, Anthony's group just published this last year where they compared all the three modalities, which was a multinational study between China, India, and Japan, where they compared the EPAS to a enteral stenting as well as surgical gastrojejunostomy. And the procedure time was longest with the surgical group versus the EUS-GJ had the shortest hospital length of stay, lowest rates of recurrent obstruction or need for intervention, and the highest rate of goose symptom score with the EPAS. So it has definitely become the mainstay, and in our institution has in fact become the first line, even over enteral stenting, as long as there is a safe window to be able to do that. So I'm going to switch gears and talk about EDGE procedure in a Roux-en-Y gastric bypass. And normally for papillary access, for ERCP, we would go through the esophagus, through the stomach, and get transpapillary access into the bile duct. However, this is challenging in altered surgical anatomy, such as a Roux-en-Y gastric bypass. Traditionally, in the past, you could do a device-assisted deep enteroscopy and be able to get up to the papilla. The only limitations become the devices that we use for ERCP obviously are not long enough for this, and the need for a side view because we're coming from upside down view. To bypass this challenge, we had the lap assisted access where we would need the help of our surgical colleagues and get lap access into the remnant stomach and do ERCPs. And the benefit of that is that we would be able to get access to the papilla with standard devices. But we're dependent on the surgical techniques and the OR availability and the combination. But this has been a game changer where we've now come up with this EDGE procedure where we as interventional endoscopists are able to get access into the remnant stomach and still use our traditional procedures and devices. So this is kind of the best of both worlds where we have endoscopic access and we can still use our traditional endoscopic equipment. So this started back in 2015 where Michelle Kahela's group with Prashant first published about this technique, but at that time it wasn't a single session EDGE, and it was actually a percutaneous access. So they got access into the remnant and then put a PEG tube and then an esophageal stent and then went in through that. But then with the advent of LAMS, that's definitely been a game changer. So this is an appropriate title saying EDGE game over, because now we're able to get endoscopic access without any percutaneous or surgical access. And since then, this has kind of become the standard of care again. So I'm going to again start with this case of a patient who was a 65-year-old female with a Roux-en-Y gastric bypass, presented to an outside hospital with biliary obstruction without interventional endoscopy availability. So to temporize the patient, they placed a percutaneous drain for her obstruction, and then patient was transferred over to Geisinger to my care. And we got an MRI that showed a distal CBD ampullary obstruction, but we weren't sure if this was a pancreatic malignancy or a biliary malignancy or a duodenal malignancy. So, you know, when life throws lemons, you got to make lemonade. So because we had percutaneous access, we were actually able to get a percutaneous cholangioscopy performed in coordination with our interventional radiology colleagues. And we did see that there was actually a papillary obstruction, a distal CBD obstruction in a papillary tumor-looking area with a percutaneous cholangioscopy. So this actually emphasized the need for getting an endoscopic access in this patient. So now that we knew what we were dealing with, we proceeded with an EDGE procedure. So here you see the remnant stomach and this sand dollar sign where you see this, the remnant gastric area. And then under EUS and fluoroscopic guidance, I insufflate the stomach with a EUS needle and then do a freehand puncture access and place a 20 millimeter LAMS. Now, this is my go-to size for EDGE procedures, and I'll show some data around that. But my stent of choice is a 20 by 10 LAMS. And lo and behold, we were able to find the ampullary obstruction, which was this huge ampullary adenoma. I do single session procedures, so single session EDGE, especially in cases like this. where we're able to dilate the stent and be able to go through it and then perform a therapeutic maneuver, which could be choledocholithiasis, or in this case, it was a large ampullary tumor. And we were able to do an endoscopic ampulectomy, almost a 2-centimeter mass at the ampulla. And then in the same session, we were able to do a intraductal cholangioscopy and rule out any intraductal extension. So this was kind of a therapeutic as well as a staging procedure all in one, where we were able to get rid of the ampullary tumor as well as clear the bile duct of any intraductal extension. So we have shown the feasibility of EDGE procedure with various multi-center studies where there is a high clinical and technical success rate with an acceptable complication rate. And this could easily and safely be performed as a single session procedure as well. So again, multi-center outcomes where we were able to participate and show that doing a single session EDGE was technically feasible and safe. And here is where the difference shows us using a 15 versus a 20 millimeter stent. So with the advent of the larger diameter stents, this has facilitated us to be much more proactive with our patients and reduce the number of reinterventions. This was a study, again, supporting that same thing about 15 versus 20 millimeter stents, showing a higher rate of single-stage EDGE procedure in patients who undergo 20 millimeter LAMS. And then Truptesh and I, we had coordinated in writing a review of all of this data around the EDGE procedure, showing the various illustrations and the techniques available currently and the outcomes of the EDGE procedure, either as a gastrogastric access or a jejunogastric access. And I'll switch gears a little bit. I know while we're having different acronyms from EDGE, we'll go to EDI, which is another different kind of bariatric surgery where there is a biliopancreatic diversion. And in this case, there is no stomach to edge into. And to get biliary access, we have to basically connect the duodenum to the duodenum or the jejunum to the duodenum. So this was a patient of mine with a history of biliopancreatic diversion bariatric surgery who recently underwent a liver transplant and developed a biliary duct-to-duct anastomotic stricture with elevated LFT. So obviously there is a lot riding on this. This patient had a recent transplant, is on immunosuppression. The transplant surgeons are worried and they want to see what we can do about it. And the MRCP here confirms this anastomotic stricture with intrahepatic ductal dilation. So on EUS, we were able to find through the stomach this anastomotic obstruction and in severe intrahepatic ductal dilation, along with a target in D2 that we can eddy into. So I was able to find an enteroenteric access and able to get a 20 millimeter hot axios into that area. And then again, same session, we able to dilate the stent. In this case, I did anchor the stent because it's an enteroenteric access. So the stent is easily slippable, in which case anchoring helps stabilize the stent. And I was able to do a same session ERCP. And you can see here, there is almost a complete ductal obstruction that I was able to successfully traverse, dilate, and then stent in the same session. And this patient came back for a 3-month follow-up, and upon removal, the stricture is completely resolved. So these procedures definitely have a life-altering and organ-preserving outcomes. So I know in the past when we were in trouble, we used to call surgeons, and now we're at a time where when the surgeons are in trouble, they call us for help. And to kind of make things more getting into the soup alphabet, you know, from edge to eddy, but can we get edgy? So this was something that we participated again in a multi-center study of patients where we combined these two procedures with the EUS-GE access and then do an ERCP through that. So we had 45 patients who underwent EUS-GE for a gastric outlet obstruction, but then subsequently also developed biliary outlet obstruction. And we successfully used the EUS-GE access to do a retrograde ampullary access. So this edgy case of mine was a patient with pancreas head adenocarcinoma with a malignant gastric outlet obstruction who had undergone EUS-GE for nutritional need and then subsequently developed obstructive jaundice. And I was able to use the EUS-GE access because it was impossible to traverse through the duodenum, and then retrograde, place a fully covered self-expanding metal stent. And now the patient's EUS-GE access could be used for very quick and easy biliary access as well. And thus we can get edgy about it. Specifically, in just last couple of minutes, I'll go over some of the EDGE and EUS-GE associated complications. Anthony went over many of these things, but one of the things that we published on was this false sand dollar sign, that you can miss the target organ. Here, I thought this was the sand dollar, but apparently that wasn't, that was a colon. So that's why the need to do this under fluoroscopy, where we get an enterogram, and just with a needle puncture, if you don't confirm, then you can get into problems. And the reason I couldn't find the real sand dollar was because the patient in the remnant had developed gastric cancer. So this is the remnant stomach completely distended with tumor, and that's why we couldn't see it initially, but hence the need for this. And here, this is a jejunum. So this was a again, patient with a gastric bypass, where the jejunum could look like the stomach, and this is what the real stomach looked like. So just being careful that you need EUS and fluoroscopy. Stent migrations, where we place the distal flange is important. This was just from last DDW, 250 patients, and there was an 8% LAMS migration, which was a 3-fold increase if the flange was placed in the distal antrum versus the body. So body is a better target because in the antrum, the scope loops up and then causes this. So if you have a peritoneal view, that's absolutely something that we don't want to see. But rather than panicking or patient needing an emergent surgery, these are the things that we can salvage now, either by closing the perforation with a over-the-scope clip or using endoscopic suturing devices, or as Anthony also showed, placing a stent in stent technique. So this is an edge that we saw after the ERCP was completed. As you can see with the cholangiogram, on the way out, the stent had slipped out of the proximal stomach, and you can salvage that by placing a fully covered esophageal stent across of it. Or what I've also done is, if it's a short throw and it's close, then I can do a LAMS via LAMS procedure as well, where if the distance is less than 1 centimeter, I land the distal flange of the new stent into the proximal flange of the old migrated stent and be able to seal the perforation, and this gives a better traction as well. So whatever we can salvage, whatever works. EUS-GE, we had published on this as well, on the classification of stent misdeployments, the type 1, 2, 3, 4, based on what we puncture. Either we puncture the stomach or the jejunum or the colon. And as you can see, the most common one is this the stent not puncturing the jejunum, as Anthony showed in his video, where the distal flange does not land up in the jejunum. One of the other unique things that we collectively, Truptesh and us, our group together, had collectively shown is this misdeployment through the colon. So when the stomach is distended, this is a case where the colon is decompressed. As you can see here, there is a colon riding just underneath the stomach. And under EUS view, it's easy to kind of push it out of the way, but do we really? So here is the jejunum, here is the stomach, and we were able to do an EUS-GE from the stomach into the jejunum very clearly and show that this was placed into the jejunum. But 2 weeks later, patient presented with severe diarrhea, abdominal pain, and then on CT scan, we found that the stent had actually moved into the colon. Now, we clearly did not place into the colon, it was in the jejunum, but how did it end up? Is basically the colon was interpositioned between the access and had, here you can see the scope coming from the axios into the colon, and we can solve many of these endoscopically. So we were able to remove the axios, close both the sides by an OTSC clip. So the colon perigastric wall as well as periperitoneal wall were both closed endoscopically through a colonoscopy, and the gastric perforation site was closed with an endosuture, and we were able to successfully salvage this endoscopically. And then on hindsight, if you see this sliver of an organ, this is the colon interposition in the middle. So it's very easy to miss that, where the distance between this was less than 5 millimeters, but there was a decompressed colon because the patient had been malnourished with a gastric outlet obstruction. But eventually, because of the EUS-GJ, when patients started eating, this colon expanded and the stent fell out of the jejunum and landed up into the colon. In growth, sometimes we place these stents for patency, but the stents themselves can get occluded. So if it's for a benign indication, as we just recently saw, the stents could be removed and exchanged out. So I replace them annually if it's for a benign reason, or if it's for malignant, then it can stay in indefinitely. So to summarize, proper training, credentialing, having the right infrastructure, and most importantly, having the right partnerships with surgery, IR, critical care is very vital. So in interventional endoscopy, we keep trailblazing our own way. And then when literally things hit the fan, keep calm and scope on. So thank you, everyone. And that was kind of my trials and tribulations through EUS-GE and EDGE.
That's great. So now we have a plethora of questions. I'll ask Amol to begin the questions from our audience.
Okay, great talk. I think all the 4 talks were fantastic. And let me welcome Manolo. I think he's just joined. Well, welcome, Manolo. Thanks for joining in. I know you're busy in a family gathering. So let me put out the first question to you. So
Okay.
Radhika Chavan from India, she asks that, is there any advantage of an EUS gallbladder drainage over a EUS choledochondrostomy in malignant biliary, distal bile duct obstruction? What would you choose, CDS or gallbladder drainage? And when would you do what?
Well, that depends on a number of factors. First, how dilated is the common bile duct, and is the cystic duct patent or not? Those are the critical anatomic factors. If the bile duct is dilated up to 18 millimeters, I think choledochondrostomy should be tried. And if the cystic duct is not patent, I don't think there's any role for biliary drainage through the gallbladder, because it's anatomically impossible. So in between those 2 extreme circumstances from an anatomical standpoint, that is a huge CBD and a blocked cystic, you have a range of factors. But theoretically, choledochondrostomy provides a longer lasting biliary drainage, because with tumor progression or just through a long tortuous cystic, even if there is no tumor blockage, the chances of obstruction down the patient clinical course are higher. But I would say that nobody has looked at that carefully, prospectively compared. So it's just a little bit of speculation. The other important factor is operator confidence. Sometimes with a patent cystic, the gallbladder is like a balloon. And it's so easy that for less experienced operator, it may be safer, because in the long term, you're going to get biliary drainage. So, and if should obstruction occur, you can deal with that electively, which is always easier and safer. There's less chance of leakage. I don't know if I answered your question, but that's my thoughts about that.
Thanks, Manolo. Truptesh, you want to go next?
We have one question from Ravindra Gade. Hi, Ravindra. Thanks for joining in. The question is, what will be the maximum amount of necrosis and walled-off necrosis where you will say no to endoscopic drainage with LAMS or any other stents? I would start with Sudipta, and then all of our expert faculties can chip in.
I don't think so. There is a particular number that we can put to it, because if you look back at what actually produces symptoms, it's the pus under tension. So for relief of symptoms and decreasing SIRS in this group of patients, all you need is to drain the fluid which is there. The amount of necrosis actually has no bearing on the outcome. Of course, it increases the number of iterations that one has to do to remove the necrosome from inside. But beyond that, I don't think so. There is a particular number that we can tell.
Thank you.
So anybody else has any comments? Sudipta, one question regarding this, just an extension of this. So would you use an EUS guided approach even as a stopgap kind of a thing to optimize the patient, even if you feel that they may require surgery or percutaneous necrosectomy or something later? Would you?
Yeah, so Many a times, actually, it's a priori decision actually, and that's primarily in the early phases when the person is having significant sears. In those circumstances, just draining that pus itself will reduce his symptoms. Now, whether you do it percutaneously or you do it in the EUS guided, it doesn't matter. It's for us, it is the person who has the access should do the drainage. If the access is better in the percutaneous route, do percutaneously. If the access is better on the EUS guided, the collection is in the lesser sac or close. It's very easy to do an EUS guided drainage. But it's just about the access. It's not about whether you do it percutaneously or EUS guided. Take out the pus, reduce the symptoms.
So
Okay.
I can add just a quick point to that, and I agree with Sudipta. I don't think there is a maximum number because transgastric access gives us the opportunity to go back in for reintervention, for subsequent necrosectomy. The only caveat I would say is there is a handful of cases where there is absolutely no window, where the entire cavity is just solid necrosum. And in that case, what has happened is if you deploy the Axios or any LAMS, you cannot see where the flanges are landing. It's that packed with necrosum. And in that case, what I've selectively done is get a percutaneous drainage first, just to get the decompression, and then use that as a lavage to put some liquid or do an EUS-guided under fluoroscopy, an EUS-guided contrastogram and get a better target rather than a pure EUS-guided drainage. So that's the only caveat. But other than that, I don't think there is a number to drainage.
So Anthony, I have a question for you. Regarding adverse events after LAMS, bleeding, erosion, and occlusion. So there is data on putting in double pigtail stents. We all do that. But is there any really, evidence that double pigtail stents prevent or reduce the incidence of, bleeding or erosions or even occlusion for CDS, for example, many?
I think for pancreatic fluid collection, definitely there's evidence that plastic stent can reduce bleeding. For CDS, I think there is a randomized trial comparing plastic with plastic and without plastic stents, and I think Manolo has showed that trial, showing that the use of plastic stent actually reduces blockade in the CDS. So, but for us, we don't do it routinely for CDS. We try to place the stent at an angle to the bile duct, and if that's possible, then actually we don't put a plastic stent.
There's a question from Hamid Raina. Can EUS cholecystogastrostomy be used for gallbladder stone removal in future? I would open that to all four faculties over here.
Well, it's been done not in the future, in the past. Anthony was one of the first to report prospectively on transluminal cholecystoscopy for a number of interventions, ranging from biopsy, polypectomy, and including also stone removal, which, as I said during my presentation, was per protocol, including an elective 4-week follow-up in the drug trial patients that were randomized to EUS-guided gallbladder drainage. So it is technically feasible, it is doable. The question is, does it provide any advantage? Is there any evidence? And if so, in what type of patients? Because the stone burden is not the same for every patient. There are patients with a gallbladder which is packed with stones, others just have a few soft sludge-like stones. So there's a lot we need to learn in the future about what I call management pathways changed by the EUS-guided intervention. So it's possible, and it's been done, it's safe. And the question is in which patients that we need to address in the future, and with what protocol. I don't know, maybe Anthony has something to add to my comment.
Definitely agree. Actually, in our prospective study for surgical patients, we found that those patients with less stone load actually have a better outcome, meaning they have less recurrent stones and they have less problems after the complete stone clearance. But in patients with larger stones, like say more than 2 centimeters, it actually takes a lot of effort to remove the stones. It takes a lot more sessions, and sometimes it's very difficult. So yeah, it really depends on the patient.
Okay. So there's another question that in patients with malignant gastric outlet obstruction and biliary obstruction, if you're not going to be doing a EUS-GE, but you want to do an EUS-guided biliary drainage, would you prefer a CDS or an HGS? Meaning, again, the question is open to all four.
I think that's for me, Amol, because I don't know if I have time to go into detail, but basically, choledochoduodenostomy is more prone to stent dysfunction, recurrent biliary obstruction in the setting of concurrent duodenal stricture causing gastric outlet obstruction. So if the operator is equally confident with both HGS and CDS, in the setting of gastric outlet obstruction, HGS should be preferred because it provides a longer lasting patency. However, if the operator is not confident, it has not reached the 30 procedures landmark, maybe choledochoduodenostomy is just easier, safer, and the operator can try to leave a pigtail in order to minimize the chances of stent dysfunction. And should dysfunction occur, that's always easier to handle endoscopically.
Okay, so just an extension of this, if you do a EUS-GE gastrojejunostomy in these patients, does it help the EUS-CDS to perform better? Does it improve the patency? Because you're diverting.
Yes, it does. Yes, it does. The data are retrospective cohort studies from Japan and from Europe in Leuven, Milan, and Amsterdam. And basically, if you do GE or GJ for outlet obstruction, all patency rates improve. Whatever your biliary drainage strategy is, whether it's the left hepatic, the CBD, or the gallbladder. So a duodenal stent interferes with biliary drainage. But even within patients with GE, as a gastric outlet obstruction, patency is better with hepatogastrostomy. And if you don't have outlet fixed, you shouldn't be doing hepatogastrostomy because you're going to end up filling the stomach, which is obstructed, with a lot of bile. The patient is going to start vomiting, and there is a risk of stent dislodgement with vomiting. So gastric outlet obstruction should be addressed first, preferably with GE, and then biliary drainage, preferably with HES.
Right. I'm going to just switch questions here and combine a couple of questions together. And I would let Harshit answer this question. Post-EDGE and with ERCP, a combined procedure, when would you remove LAMS? And do you normally suture the opening of the LAMS area once you remove the LAMS? That's question one. If you can answer that in the next 30 seconds, please.
Yes, Truptesh. No, thank you for that. Yes, I do anchor the LAMS, but not every single case. I anchor the LAMP, preferably my choice is suturing because I feel that it gives a much more robust anchoring. But what I do is post-placement for EDGE, I'll try to pass an upper endoscope and look at my angle of approach. And if everything is stable enough, I'll proceed without anchoring. But if there is any looping or any resistance, then I anchor with suturing. And the other part about removal, yes, after the EDGE procedure, after the ERCP part is completed, I leave the LAMS in for about 2 weeks and then remove it and suture the gastrogastric access. Again, has to do with geographically where we are. Patients come from long distances, so I don't want the local gastroenterologist to then be dealing with the fistula down the road. And then Viral had asked about the EUS-GE. When I remove the LAMS, I can address that on the same note. If it is for a malignant gastric outlet obstruction, I do not remove the EUS-GE LAMS. I leave it in almost indefinitely. If it's for and also depends on the patient's life expectancy. If they're going to go to surgery, then that's all going to come out as part of the Whipple anyways, and the surgeons are able to fix that. If it's for a benign disease, as I mentioned in the talk, I change it out once a year. So I leave the EUS-GE and then swap it with another LAMS if the obstruction has not resolved in a year.
So an extension to that from Ramalingam is to Sudipta is when to remove LAMS after walled-off necrosis drainage.
Yeah, so usually we do not, we try to remove it within 2 to 3 weeks and replace them with double picted plastic stents, because as the cavity tends to reduce in size, the lamp still remains in position and tends to irritate the vessels on the posterior behind the stomach. Unlike a plastic stents, when the lumen of the necrosis comes down, the plastic stents tend to migrate into the gastric lumen. But in the LAMS, it remains in position, and therefore the risk of bleeding is higher. So we remove it within 2 to 3 weeks of placement.
Okay, there's one question from Dr. El Sayed. So regarding EUS-CDS, what are the advantages of LAMS over tubular stents? Because he asked that with the introduction of the benefit stent with the 5.5 millimeter delivery system that can pass directly over the wire and doesn't need even a dilatation, do you think it will be preferable to a LAMS for a CDS? So
Sorry, what is
I would want
the question?
Anthony's
Five
comment on this as well.
five French delivery catheter for tubular stents? No,
5.5 benefits.
5.5. Yes. So the major advantage of LAMS over tubular fully covered SEMS is the hot one-step insertion. So it's technically easier, provided that the CBD is sufficiently dilated, because the delivery catheter of most LAMS using the bile duct is around 10 French, which is very large. So if you did have a fully covered SEMS with a 5.5 French delivery that you can really place in one step into the bile duct, that would be good. And even better if the bile duct is not dilated. So there are only retrospective comparisons between CDS with LAMS and CDS with SEMS, and there are no differences. Theoretically, the SEMS would also block the cystic, and the chances for post-drainage cholecystitis would be like between 5 and 10%, depending on a number of factors. And theoretically, with LAMS, that risk would be less. But we don't know. I mean, the data we have so far in terms of post-procedure complications, short-term and patency, are no differences. And who knows if patency with SEMS, choledochoduodenostomy, would even be better, as it has been shown for hepaticogastroscopy patency that a longer SEMS protects against recurrent biliary obstruction. So there's a lot we need again to look at and to learn in the future regarding this procedure.
Tony, your take on this? You're muted. Anthony?
I think there for LAMS, I agree with Manolo in that the single step delivery system actually makes it much more easier to perform. So for beginners, for LAMS, I think it's easier to learn. But we do observe a bit more of some syndrome, so foot debris entering into the bile duct in patients with LAMS. And I think personally, I think the tubular stent actually there's less chance of foot getting inside with the use of tubular stents. So, but I don't think there's any study comparing the patency of the two stents. So it's still not certain.
I would have one more question before, and then Amol will ask one more before we end the session. For transrectal collection, when you place LAMS, would you treat it same way as a pseudocyst or a walled-off necrosis, and then place a double pigtail stent as a destination therapy?
So, I actually personally do not have any experience of putting LAMS for pelvic collections. We've treated them with double picted plastic stents, and then we tend to remove them as you do for any walled of pancreatic necrosis. But what I can gather from review of literature that usually you need a collection of more than 4 centimeters to deploy a LAMS. That's all I know. But I have personally never put any LAMS for a pelvic collection.
So I can take that. So the study that you had quoted, the Moody-Reddy study, that was from Geisinger from us. And the PFC, the post-operative fluid collection, had actually rectal abscesses in those as well. And so when we place the LAMS, to answer that, we don't leave any double pigtails. We treat it like a ward of necrosis or an acute necrotic collection. And then that usually drains out and the cavity collapses around the LAMS. And those are easily removable, just transrectally. But I usually don't need to leave a plastic stent. And as you mentioned, it has to be about 3 centimeters or so to have the right window. But now with the variety of the stent sizes we have, we can custom tailor it to the size of the collection.
Okay. So one final question is there any indication to do CDS in benign biliary strictures if ERCP fails, or even if those strictures are refractory after multiple stent placements or things like that?
Yeah, that's a very interesting question. We've done it in extreme circumstances, and honestly, I don't think there's any reason for not doing it as a salvage procedure in the right setting. So for benign distal biliary obstruction, the procedure, say stone or a stricture from chronic pancreatitis, rendezvous is the standard classic orthodox EUS-guided biliary drainage approach. You puncture, you try to make the guidewire go integrate through the papilla, and then you rendezvous by ERCP. However, let's say your patient has a severe cholangitis, the guidewire is not going, you have a huge dilated bile duct. If you perform choledochoduodenostomy, you provide immediate drainage, and if it's an elderly patient, you avoid surgery or percutaneous access, and then electively, you can go, once the fistula is mature, you can pull out the choledochoduodenostomy stent and work your way downstream, integrate by rendezvous ERCP. So if the patient is sick, if you fail with rendezvous, yes, you can do it if you are experienced, but knowing this is an out-of-the-box or off-label approach not endorsed by guidelines, we need more data to make it fully legit.
All right, with that, we end the session, and I would like to thank all our faculties and the audiences for staying in for an extra 7 to 10 minutes. And I will hand over to Amol for the future announcement. Amol, all yours.
Okay, thanks everyone. I think it was a really wonderful interactive webinar, and I think a lot of questions were asked. I think most of the questions we could answer them, and we could cover all of them. So a big thank you to all the speakers, all the audience. We would also like to extend our heartfelt thanks to Boston Scientific Corporation once more for their wholehearted support for this academic initiative. We always know that because this is a global webinar, that a lot of attendees register for the event, but not everybody can join in at the same time because of time zone differences. And that is the reason the recording of this webinar will be uploaded on the Free Endoscopy YouTube channel within the next 2 to 3 weeks. And we request all the attendees to subscribe to this YouTube channel so that you can receive regular updates and regarding our, and also to the Free Endoscopy website for updates regarding other academic events. Our next webinar is scheduled on June 15th, which is again a Saturday. It will be 6:30 p.m. Indian Standard Time, and it will be 9 a.m. Eastern Standard Time. We will come back to you with the topics and the faculty and the speakers. So keep watching this space. And with that, Have a great evening and a great weekend. Bye-bye till next time. Thank you so much. Bye-bye.
Thank you guys. Bye. Bye.
Thank you, everyone.